Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
All right, what's up, everybody? It's Erin Faules, one of the premium docs at Wild Health. Excited to be back. Today, I am with Dr. James Min. He is awesome. He's a cardiologist and former professor of radiology and medicine at Weill Cornell Medicine, where he directed the Dalio Institute of Cardiovascular Imaging at New York Presbyterian Hospital. He has more than 500 peer-reviewed publications and leadership roles in multiple landmark imaging trials. His work has helped establish the coronary CT as a core tool in modern cardiovascular prevention. He is the founder of Clearly, something we're going to talk about a lot today, which applies validated imaging science to improve early detection and management of coronary artery disease. So why this matters is that for a very long time, cardiovascular disease has been the leading cause of death, right, Jim? I mean, not to start on too morbid of a note, but this is super, super important, and the work you do is wildly popular at Wild Health. And I think our listeners are going to find this to be a super interesting conversation for that reason. This obviously matters globally because this is a problem. So we're so excited that you do what you do. I'm glad to have you on today and get to know you a little better. And thank you for being here.
Thanks for having me, Erin.
Yeah. And just as an aside, everyone, Jim and I also realized we are both from Oklahoma. So you've got a couple of Oklahoma natives here chatting with you today, which doesn't happen every day. So I was excited to learn that we have that in common as well. So,
Yeah, go Sooners.
yeah, right on. Cool. Well, let's dive right in. So if you don't mind, you obviously have a pretty interesting background. I imagine you didn't initially see yourself doing this forever. I could be wrong. But what if you don't mind sharing with us what led you down this path to starting Clearly, if you could give us that story in a nutshell?
Sure, absolutely. So, I'm a cardiologist by training. I trained at the University of Chicago, and I moved to New York in 2005, and that's when we adopted this coronary CT scan of the heart. We were aware that we didn't fully understand it, so I was sort of the quintessential academic physician. We ran a lot of clinical trials using the CT scan as a tool to better understand coronary heart disease, the cause of heart attacks and sudden coronary death. And we learned a lot, things that surprised us. And when we had those realizations, we decided, it's one thing to find things that meaningfully predict somebody's risk of dying or having a heart attack. It's another thing to do something about it. So about 12 years ago, we started a clinical program that adopted a lot of the research findings that we did, took a very different approach to personalizing evaluation and treatment of patients with coronary heart disease. And we hired 5 cardiologists, called it Heart Health, which was the program name, went for 7 years and really had just massive success in preventing events. So we realized it was a very manual process at that time, and we couldn't scale it. It was taking us 8-10 hours to analyze a single patient's imaging study. So we
Wow.
wanted to start Clearly to really shepherd this concept out into other institutions beyond Cornell. So we started Clearly to create a care management platform. So we never tried to create a test, never tried to create a single metric, really wanted to have a centralized place where you could really get comprehensive care, evaluation of coronary disease, education of the data and what it means for you, helping to guide physicians to do effective treatments, and then tracking disease across time to make sure that we were being successful with our treatment. So we're about 8 years old as a company. You're right. I never thought I was going to jump out into industry, but I felt that there was no way that I could actually implement the research findings unless we created products that could be used by physicians and patients.
Yeah, very cool. I could tell you some stories, and maybe we'll get into some of it today of specific lives that your test has affected just from the patients I've worked with. So this is, I have firsthand seen the impact that this kind of data can provide. You've alluded to a lot of it in your answer just a moment ago, but if you wouldn't mind just explaining for anyone that's completely new to this, because we do have a lot of physicians and a lot of really well-versed patients that listen to our show, but there's some people that are brand new to this as well. So if you wouldn't mind just explaining in a nutshell what clearly is for people that aren't up to speed on that yet.
Sure, absolutely. So we are a digital healthcare company that leverages the coronary CT angiogram to analyze patients' heart arteries to ensure that they can be treated effectively and diagnosed with coronary heart disease. We use that coronary CT angiogram as a software as a service, so we're a cloud-based solution. All of our fulfillment is can be seen on a web browser, and specifically, what we're looking for is the actual heart disease. So if you think about historically, we sort of waited for people to get symptoms, right? And we're a very symptom-driven field, so chest pain, shortness of breath, that kind of thing. And then we would put people onto treadmills and take pictures of their heart doing stress tests, looking for a concept called ischemia, or reduced blood flow to the heart muscle. And then if that was positive, we would send them for an invasive angiogram and look for a blockage in the arteries that maybe might benefit from a stent procedure or something. And if you think about symptomatic heart disease, ischemic heart disease, and the stenosis or narrowings causing angiographic heart disease, the commonality between all three of those is that they're adjectives, not nouns. Like they all describe heart disease, some form of it, but it's not the disease itself. The disease itself is the plaque that builds up silently in the walls of the arteries over many, many years. And then as that plaque grows, it can encroach upon the lumen of the vessel where the blood is flowing and cause a blockage. And that blockage may become severe enough that the plaque and the narrowing might cause a reduction in blood flow, and that's when patients become symptomatic. So that's an important thing because I think that our tools now have demonstrated the highest diagnostic performance in the published data. But it's also important because the vast majority of people who will be missed by stress testing, and the majority of people who will die of a heart attack or suffer one will never have a symptom before their event. And so what we wanted to do was really create this care management platform that leveraged atherosclerosis or plaque across the continuum from the earliest stage when it can be prevented to the latest stage where it needs intervention. So, really, from prevention to intervention is what our care management platform offers. And then the only other thing I'd say is that not all heart disease is the same. There's many, many different forms of heart disease. And what we do is we found that not only the burden or the amount of disease that you have, but just as importantly, the type of disease that you have is very, very important. And that's what the CT angiogram allows you to do, is to characterize the morphology of the plaques so that you can see what has been proven in the literature to be the stable plaques that reduce risk of heart attack, or the very, very high risk plaques that are the strongest predictors of who's a heart attack risk person. And then what we also know is that all of our therapies are very effective, but we need to identify the people who are benefiting from the therapies or not. What are those therapies? They're all medical therapies or lifestyle modifications, but it turns out you can transform plaque from unstable to stable, or from dark to bright, and so on. And you can watch that quantitatively over a patient's lifetime so that you can make sure that you're actually keeping them healthy.
And your technology with Clearly allows this type of morphology of plaque to be determined, right?
Yes.
As opposed to just a traditional calcium score, say, where you're just picking up on decalcified plaques alone, right? Or a traditional CT angiogram of the coronary CCTA, where you're able to see plaque distribution appropriately, but you're not actually able to determine how dense are those different plaques, right? How stable are they, right? Like, is
Exactly.
that essentially the
Exactly.
differentiator for, especially for our docs out there that might be curious of what this adds? I think that's definitely what we see as the most appealing aspect, especially for our younger patients that almost certainly would have a completely normal calcium score, which is what a lot of people ask us about when they come in, right? well, I had a normal calcium score, or should I get this? My friend got this, as a screening tool. But it's going to completely miss those less stable plaques, right?
Yeah, agreed. Like, so I probably published over 100 papers on coronary artery calcium scoring. When I started doing the research, it was 20 years ago, and it was definitely a step ahead. But what we realized with all of the clinical trials is that the calcium is not the problem. The calcium is like a sunspot. That's where the risk of cancer used to be, not where the risk of cancer is today. The risk of cancer today in the heart arteries is this very fatty, lipid-rich, cholesterol-filled plaque that can be identified through um, sort of the density of the plaque. And so the dark plaques on CT, which are very, very difficult to quantify from a human standpoint or a manual standpoint, but the AI can do very, very easily, can really find the strongest predictor of who's going to have a heart attack and who's not.
Yeah. And then that can help guide therapy. I mean, in my experience, this is a huge differentiator in our younger patients that are really hesitant to start on any sort of pharmacologic. As an example, it can be the difference maker when they're seeing this on a piece of paper, right? And they're seeing the level of unstable plaque that they may or may not have. It can really be a game changer for them in real life, in one-on-one conversations that we have. And then even to take it a step further, it can guide changes in therapy over time, right? If you repeat this image and you're seeing maybe the calcium score has gone down, maybe the calcified plaques have gone down, but the lowest density plaque has increased, which is going to be the least stable, correct? And so you're going to want to change that therapy, even if your lipids are at goal and your calcium score has gone down. This patient in prior imaging or prior criteria might have been thought to have improved, right? But if you're actually seeing that low density plaque go up, you're gonna want to guide therapy to make shifts and then look at that over time, like you mentioned. So it can be just phenomenally helpful as a practitioner to help guide individualized therapy for people because they're gonna, in my experience, people respond really differently. Some people I see those unstable plaques improve over time on the same therapy that with another patient didn't, right? So it's really cool for from my perspective to be able to look at this in real time with people.
Yeah, I think you raised some very, very important points. Like, calcium is definitely an age-dependent process, right? So when you see somebody who's 50 and has a calcium score of 0, that does not mean anything, right? Because, right, usually the evolution of plaques is thought to be that you start very non-calcified, and then you get denser and denser and denser over time to calcify it. That takes time, and so for young folks in their 40s and 50s, like, to me, a calcium score, you have not ruled out coronary heart disease until you actually do a contrast-enhanced coronary CT angiogram looking for, what the field, the peer-reviewed literature calls high-risk plaques, and those high-risk plaques are, very low density, cholesterol-filled, fatty-filled, and so on.
Yeah, nice. Um, cool. Well, on that note, when we're talking about age, what do you all have as a company age recommendations for when to start this kind of imaging, or are you able to share? Do you know the youngest demographics that you guys typically get images on? What kind of information can you share there? Because I know this is going to be of interest to the type of people who listen to this show.
Yeah, I mean, once I moved into the industry, like we stopped doctoring, nor are we allowed to doctor, right? So as a FDA approved or cleared device, like we're a decision support tool that is here to support the doctors, not supplant them or make any specific recommendations. I make some observations on how it's being used in the field. Like I definitely don't see a lot of folks in their 30s, but starting in their 40s, it seems to become a lot more common. And 40s, 50s, 60s, 70s is where we're seeing the majority of the patients come in. And they come in for a myriad of reasons, right? Like, particularly in your population, like, these folks who, recognize that, like, the majority of people aren't going to have symptoms before their event. And, everybody knows somebody like that, somebody who went out for a run and didn't make it back, or who went to sleep and didn't wake up, and everyone knows somebody because it's the most common cause of death, and so what we're trying to do is prevent that, and so particularly for those who are proactive, we see a lot of people, sort of trying to get an earlier diagnosis for this. We want this, we want to prove this out. And so we are running a very large randomized controlled trial called Transform. It's a screening trial, and it's 10,000 patients that we will enroll. We've been enrolling for about a year and a half now and have enrolled about 6,500 patients to date. And what we're testing in Transform is the question of, in a completely asymptomatic person, is the evaluation and treatment of risk factors of disease like cholesterol, blood pressure, diabetes. Is that better, or is it better to do evaluation and treatment of actual disease by imaging? And that sort of takes a page out of the playbook of what mammograms over monthly breast exams, colonoscopies over fecal occult blood testing, um, lung CTs over chest X-rays, even Pap smears, right? What are the commonality between all four of those blockbuster successes in medicine is that they all use some form of non-invasive imaging to directly visualize disease at the personalized level at a point in time where things can be prevented. And that's, I think, something we've never done in cardiology. We've been a very symptom-driven field where we thought it was the symptomatic person with chest pain who was at risk. And if we could somehow relieve the symptoms, we'd reduce the risk. There's at least a dozen randomized control trials that have debunked that theory. So what we should do is we should instead not be treating symptoms or surrogates, but treating the actual disease itself. And to do that, you have to understand the plaque because the plaque is the disease.
Yeah, our patients are going to love this because you're talking about the ultimate precision medicine, right? You're no longer looking at population based theory and potential, right? Based on how the average person responds to that risk factor. You're looking at that individual's arteries, right? And do they have disease and are we treating that disease? So I think it's phenomenal. We can individualize risk factors quite a bit as well. I'll say a little bit about how we decide if we're going to get a clearly exam on someone below 40, which is not super common, but occasionally we're going to get this kind of a image on somebody if they have a sky high LP little a, if they're an ApoE44, if they have a really high, polygenomic cardiovascular risk with a strong family history, usually a really high ApoB. Like usually it's a combination of those things. And like at the same time, we're always addressing the lifestyle factors for endothelial dysfunction and the other things that we know culminate in cardiovascular disease, right? We're always addressing their blood pressure, their blood sugar, their inflammatory markers, all these other things at the same time, right? But like if someone has certain, especially genetic risk factors, if they've got a really high lipoprotein A, it's oftentimes reasonable by 40 to get this kind of an image. And we're seeing sometimes people in their 30s with pretty significant multivessel plaque, early, softer plaque, like what we're talking about. So it's really interesting. It really changes the trajectory, at least of how aggressively that's visualized over time, how seriously they're going to take that, how seriously they're going to take their risk factors at a really young age. And hopefully that somebody that we do avoid that heart attack that would have maybe happened in 10 or 15 years for that individual. So that's, we don't know on a one-to-one, but that's our hope certainly.
I mean, your concept around precision medicine or personalized medicine is like so key. Like, I think that you just hit the nail on the head. So I think of cardiology as the most evidence-based field in medicine by far. Like, and we, and we rely upon the mechanism of the randomized control trial. And that's great because it proved something works or doesn't work. There's a couple of limitations to the randomized control trial, which is I can tell you which groups of people are sicker than which other groups of people. But within each of those groups, I cannot pinpoint which individual is sick or healthy. And so I'll give you an example. Let's say you took a bunch of people over on the left and a bunch of people over on the right, and one had high cholesterol, the group did, and the other one did not. Is the group with higher cholesterol sicker? And the answer is yes. But it turns out 70% of the people showing up with heart attack have normal cholesterol. So it's not a great diagnostic. And then in the sicker group who has high cholesterol, if I treat somebody with like a medicine to lower their cholesterol, I usually get about a 20% relative risk reduction, which sounds great. But that means 80% of the people didn't benefit, and I don't know who they are. So while I can compare so we have to get past the stratified medicine into personalized medicine, because in the office I only have one patient in front of me. I don't have 10,000
Right.
patients. So I think that your concept of doing precision care, where you said, look, we don't do a lot of patients in their 30s, but the right ones we do. Yeah, that's exactly, I think, how like I applaud your approach to treating people.
Nice. Um, yeah, and it's a little tricky, right? Because we don't have I can't say for sure that's gonna happen to you, right? Because it's not the 10,000 people, right? Like they're not necessarily the average that we're looking at, but we do the best we can when we get a number of data points and weigh it out. We do the best we can to personalize that approach, which is awesome. We obviously get excited about it, which is why we're here. Cool. Let's talk a little bit more about some of the other research trials that you have going on. I know we talked about a couple briefly before we started the recording. You just mentioned one, the Transform, I believe. Would you like to share a little bit more about some of the ongoing research that you guys are a part of?
Sure. Yeah. I mean, we've done, the whole DNA of the company is research, right? We did research for 20 years in clinical trials, and we want to make sure that when people use clearly, that they understand that we've been extremely methodical about proving its value to the healthcare system. So, the first question that we asked ourselves is when we do these studies, like how accurate are we? And so what we
Mm-hmm.
did was we tested against every invasive gold standard that we could think of. So things like quantitative coronary angiography, intravascular ultrasound, and all these fancy things that you really need a wire in the actual artery to measure and demonstrate a very high performance. One interesting thing that will be, I think, maybe interesting to your listeners is that we also said, like, when we got the initial AI outputs, we're finding these very tiny plaques. And people said, "Oh, how do you know that's not just an imaging artifact rather than plaque?" So we did a study that we published looking at about 500 lesions that had serial follow-up. And we wanted to ask the question, when we see something, what's the smallest plaque that we can see that actually just gets bigger over time and becomes a plaque that you need to treat with medical therapy? And it turns out it's about 2 cubic millimeters, just tiny, tiny, tiny. And the reason I think that's important is because when you look at the way you treat coronary heart disease, when you get it early, you can manage the condition pretty well. When you get it late, it's much harder to manage. The horse is already out of the barn. So if you can get it very, very early, now you have a choice between modifying lifestyle. Once you get to a certain level of disease, then it's just medical therapy for the rest of that person's life. So I want to find this at a point where you can modify lifestyle in a beneficial way to stop disease progression.
Yeah, rad. I think that's going to be appealing to a lot of the people that are listening as well because it's a group that's not super excited to start on medications forever, like you mentioned, right? One thing that I think is cool, I don't know that you'll speak to this because it's a completely different body system, but we know in medicine that that what's probably happening in one group of arteries in a similar size in other areas of the body is probably happening there as well, right? If you have a certain level of disease in the coronary arteries, there's likely a similar distribution of disease in arteries in the brain, the extremities, etc. Correct?
I think yes and no. Like, I mean, we call it atherosclerosis, and there's plaque buildup in other vascular beds, the lower extremity arteries, the carotid arteries, the intracerebral arteries. And they do correlate on a group
Mm-hmm.
level, but they don't necessarily overlap completely on an individual level. So there are patients who have severe, severe carotid disease experiencing many strokes that have no coronary artery disease at all. And so, but I think that in general, the beauty of this is the one that kills you most commonly is heart attacks, and treatment of that atherosclerosis in the heart arteries is systemic. So it also treats the carotid artery atherosclerosis and the lower extremity artery atherosclerosis and the cerebral artery atherosclerosis. Like what's coming out is like some data to suggest that a lot of the dementia diagnoses may just be plain old garden variety plaque buildup in the intracerebral arteries.
Right. Yeah, that's what I was gonna get at. I mean, you're looking at this one aspect, within the coronary arteries, but the shifts you make in your lifestyle or pharmacologics or whatever intervention might take place is going to benefit you in your vascular health at large, right? So that's something that's really cool for our patients because we're looking at all of those things, right? We're doing precision medicine for the whole body, and heart disease starts decades before heart attacks typically, and so does dementia. And other forms of vascular disease. So it's not just that you're treating the heart when you're making these interventions, which is a really cool application. Um, Very cool. So let's talk a little bit about uh, if someone's listening to this and they're curious, they now know what clearly is, how it might benefit them because it's not invasive like a heart cath. You're not waiting until disease is so severe that you're having symptoms. You can get a look inside your arteries in a non-invasive way and look at, do you have heart disease? Does it need to be treated? Are you treating it effectively with your current methods if you are already on meds or what have you? Like, how does someone get this? Did they just ask their doctor? Can they order it? Is it covered by their insurance for people that are just brand new and listening? How would you address
Yeah,
that?
it's a great question. Like, I mean, in traditional medicine, like we typically wait for symptoms in cardiology, right? When the majority of people won't have symptoms before their event. But historically, the insurance providers have covered things when people become symptomatic. It's a pretty late stage at that point in time, but it's an important population of people because they are at risk and they are experiencing symptoms, and we want to relieve them of any adverse symptoms. So we worked pretty hard over the last 5 or 6 years to work with the American Medical Association to establish CPT codes. And then just this year, Medicare announced a national payment reimbursement for our advanced plaque analysis that will begin in earnest in January of next year. Since Medicare announced that, the United Healthcare and Cigna and Humana and some of the Blues plans have also jumped in and also offer coverage policies and reimbursement for this as well. This is solely restricted to the symptomatic patient, right? So it has to be somebody with symptomatic suspected heart disease and then has to meet a certain criteria where you're not so severely diseased that you might not benefit from a plaque analysis because you have such bad disease. Or if you're totally normal and have no plaque, there's obviously no utility in doing a plaque analysis in someone who has no plaque. So there's some caveats, but it applies to a lot of people with symptomatic suspected coronary disease and should be reimbursed by their providers. We're working right now to try to demonstrate the clinical evidence and present it to the other providers so that we can get to uniform reimbursement. But right now, you can get it. For the asymptomatic people, that's why we're doing that landmark transform trial.
Yeah, hopefully one day this can be like, the mammogram for heart disease, right? That
We're
you're
hopeful.
starting you're
Yeah,
starting at an early age for sure. So for I formerly was a hospitalist. A lot of our practitioners were previously ER doctors. I know a lot of physicians listen to this podcast. So for patients, they may not be sure what to do if they're having cardiac symptoms. Please be talking to your doctor already, right? And hopefully they can help you figure out what the next best steps are. But I would imagine for physicians, their ears perked up when you just mentioned some of the things that you did in terms of this getting covered. I know when I practiced hospital medicine, I think the last time I practiced in the hospital was 2019. This certainly wasn't available then. But what kind of, how would they go about, like, what's the use scenario? Is it for that like symptomatic patient that's rolling into the ER or that's, you know, coming in for a chest pain rule out, and you're not sure if you want to cap them, or cardiology doesn't want to cap them, but you want to get a deeper look there. Is that who you
yeah,
see being most appropriate for this that could
yeah. I
get
think
reimbursed?
Yeah, the American Heart Association, American College of Cardiology sort of dichotomize chest pain into what we call stable chest pain versus acute chest pain. What's the difference? They can sort of present similarly, but in the one, you sort of go to outpatient imaging centers and get evaluated. And then in the other, the acute chest pain, that's when people sort of show up at the ER and things like that. In the ER, there was a concept that had been promulgated in the mid 2000s that, there was somebody who started to call this thing a triple rule out. And this triple rule out is the rule out of the three major vascular conditions that can kill somebody who presents with acute chest pain. They include aortic dissection, pulmonary embolism, and most importantly and most commonly, heart attack. And so this triple rule out didn't take off at that point in time because the technology wasn't quite there. It's there now where we can do this. And the reason I think it's important is that, I mean, historically, when I used to round in the hospital and the house staff would present a new patient to me and they said, this person came in with chest pain, this and that. And I'd say, order a coronary CT angiogram. They said, we can't. And I said, why not? And they said, well, just 2 hours ago, they had a contrast enhanced CT scan to rule out pulmonary embolism. Now you can do it all in one test where you can get all of the information. And remember, like missed heart attacks in the ER is still the number one cause of malpractice lawsuits in the US. So you can improve the diagnostic certainty. You can improve the diagnostic yield by combining three and one rather than doing them sequentially. And it should really be a very, very cost savings way to make the workup so efficient to make sure that the healthy people can get discharged quickly and the sick people can get the care that they need very quickly.
Rad. Okay, so I've heard you say that the goal of Clearly, correct me if I'm wrong on this. The goal of Clearly is your ultimate goal is to try to eradicate heart attacks.
Mhm.
Is that true to your mission? So can after having seen thousands of these images, I'm assuming, can you speak to the ability to predict the type of person that's going to progress to severe heart disease and the type of person who's not in terms of what you're seeing on these scans? Like what stands out to you the most as a risk factor, I guess I'll say in another way.
Yeah. I mean, it's that I mean, so based on the research that we did at Cornell, like what we found was that there's one common link to all important patient-centered outcomes, and that is that high risk plaque. That high
Mm.
risk plaque tends to have several features. It's bulky, it's got a lot of plaque there, and then this non-calcified plaque phenotype, in particular, the very, very low density plaques that are fatty filled and cholesterol ridden, those are the plaques that worry you quite a bit, and they explain risk, but the risk everybody thinks, "Oh, of risk of heart attack or risk of dying." Those are the most important risk measures, but there's also the risk of being ischemic, having impaired blood flow that causes your chest pain. There's the risk of being a rapid progressor of disease versus a slow progressor of disease. There's the risk of being a medication non-responder. In most cardiology trials, we reduce risk by about 20%, which means we fail in the majority of patients. And it turns out that that high risk plaque phenotype, based on our research when I was previously in academics, um, was the common explainer for all of those things. And ironically, it was just going to studying the actual disease, and then we could find all of these patients who were at risk of rapid progression, were at risk of not responding to medicines, and so on. And so, like, I think that's the beauty of it is that it's simple, right? It's a simple overlapping Venn diagram where the center of it really is just actual heart disease.
Yeah, that it comes back to that high risk plaque. What about men versus women? Are you seeing a difference in patterns in men versus women? And is that extrapolating to any difference in, I know you're not making medical recommendations, as you said, but you know, are you doing any trials on this? Is there anything from a clinical standpoint that we could take from that?
Yeah, it's a very, very important question. So we have the largest global registry for atherosclerosis is one called Confirmed 2 that we're doing. We've enrolled about 13,000 patients with 5-year follow-up in 11 countries. We really wanted to make it multi-ethnic and then target both men and women. More than half of the enrollees are women. So we can now study sort of gender specific vascular biology. We presented a large study at the American College of Cardiology late breaking clinical trials earlier this year on stratifying plaque by men and women and outcomes. It turns out women behave very, very differently than men. Um, they tend to present older, which we knew, but when they present with their risk, um, a little bit of plaque goes a long way in a woman in a negative way, meaning that they don't need as much plaque as a man does in order to have the same event rates. And so we really need to start thinking about sex specific thresholds rather than just, lumping everybody into one big group. And I think that if we can understand that, hey, if I have 100 units of plaque as a man, that's one thing. But if I have 100 units of plaque as a woman, man, I'm at much, much higher risk than the man is. So these kinds of things we're going to learn more and more over time. And I think it's going to allow us to better personalize the medicine.
And are you seeing that in like density specific plaques or just overall the degree of stenosis
The
is
degree of
has a different
stenosis.
impact on men versus women?
Yeah. The degree of stenosis, the total amount of plaque, the total amount of the dark, the fatty plaques, like all of it is lower in women. And yet
Wow.
the risk commensurate to men is at a lower threshold.
And I'm not sure in your trial if you looked at this, so forgive me. I don't know that going into the question, but are you seeing a big shift postmenopausally in these women, or have you teased that out at all in terms of when their actual risk of cardiovascular events goes up in
Yeah.
coordinates with their imaging, or when that degree of like plaque progresses?
Yeah, we haven't done that. Like, I mean, what we have done, what we know is that women tend, on average, in groups, to present about 10 years later than men in terms of suffering heart attacks or sudden coronary death. And what we also know is that it's at a lower amount of disease compared to men where they do experience their events. And then what we also know is that that age at which they become more event filled or suffer events is in the postmenopausal state, like the average age is in the 60s rather than the 50s. But what we should do, like, it's a good research idea. So we should do a very careful analysis on onset of menopause and then understanding plaque formation after menopause occurs.
I'd be so curious about HRT versus not in that
Mhm.
in that group as well, because they're at, I mean, it's historically we look at cardiovascular disease as a risk factor for someone starting HRT, but gosh, we also look at the drop in estrogen as it being a loss of a protective factor for those individuals. So it's such a curious question to me. I take care of a ton of women in peri and post menopause, trying to make this decision for themselves personally, right? So, just curious if you guys have looked at that. My other question about your research is, have you looked at any like head to head, like different pharmacologic interventions and what their clearly look like over time, to help determine, efficacy based on different types of plaque, or have you looked at pharmacologic endpoints?
Yeah, we have to some degree. Like we started this whole phenomenon looking at statins. So we looked at patients undergoing serial CT scans. This was way back even before we started, clearly, and that sort of gave us that aha moment where we realized, wait, the statins aren't making plaque go away; they're transforming it from dark to bright, from non-calcified fatty to calcified dense rocks. And that was really interesting. That a study has now been repeated with a whole host of other medications. They all have the same phenotypic mechanism where they turn dark plaques bright. They include things like PCSK9 inhibitors, icosapent ethyl, what else? Colchicine did that, a DASH diet,
Nice.
a low sodium diet, increased exercise, all these good things that we do for humans. They don't make plaque go away, they transform it from dark to bright. And so we're working with a cardiologist in Florida who has extremely good sort of medication and how that affects their biomarker levels. And so we can test the efficacy of that as it relates to plaque. And we're just pulling that data right now. So more to come on that next year.
Cool. Yeah, that'll be really interesting. Nice. Okay, so say somebody gets it clearly and they have early plaque, right? Maybe it's nothing that you want to start a pharmacologic yet. I mentioned this example because we see this example all the time. Of course, randomly we see unicorns with zero, and randomly we're very surprised by the degree of disease that needs, like intervention quickly, right? But more often than not, we see some plaque to varying degrees of significance in our patients when we're getting this test. Um, Say someone gets an image back or got some early plaque, may not make changes in terms of pharmacologics, probably will with lifestyle. Like when do they repeat this, right? I mean, you guys have protocols on this that you've looked at, correct? Like, are people getting this every year? I mean, for oftentimes, like we mentioned, for the asymptomatic patient, this is an investment, right? I would argue a really good one, given the significance of missing this. But could you speak to frequency of imaging?
Yeah, I can tell you that there was a paper that was written by an innovations working group that suggested a 4-3-2-1 approach, where if you have no disease, don't come back for at least 4 years. Like, but if you have mild, moderate, or severe disease, come back more frequently, just to make sure you're not one of those 80% residual risk people who aren't benefiting from the therapies. In our trial, Transform, we're repeating it serially every 2 years. What we see is that not much happens in 12 months, like at least that we can detect using imaging technology today. And so there's just not a lot of, you wouldn't expect much to change in 1 year, but you will definitely start to see it at 2 years. So, I'm not here to make any recommendations on
Yeah,
frequency,
sure.
because like my
Sure. Or
regulatory
at
folks would,
all, right?
yeah, at all. Like my
Yeah, we'll
regulatory
be
folks will,
clear.
yes.
Jim is
Uh,
not making medical
Yes,
recommendations.
yes. But yeah, we do see some folks doing it yearly, and I think that's probably too much, just based on
Yeah.
sort of the time and life cycle of coronary disease.
The patients that are definitely the most interested in doing that, in my experience, are the patients running self experiments with different medication regimens. We get a lot of patients that are trying to figure out, should I be on a PCSK9? Should I be on a statin, a combination? Yada yada yada. And they're wanting to look at the difference they're seeing in the density of their plaques in the interim. So we're definitely getting people nerding out on this stuff, which is cool. But that's just my own anecdotal experiment and population of patients. Um, Very cool. Well, what else would you want our listeners to know about what you guys do? This is honestly a awesome service. I imagine this is going to become more and more popular with time. But I'm just excited to get it to get this information out there for people.
Well, I guess I would wrap it up by saying this. Like, I think of eradicating heart attacks as a three-legged stool. So there's the question of like, do we identify people well enough? Do we treat them well enough? And then do we implement the care well enough? Are people adherent to the medications? Do they have social support networks where they can actually get therapies that they need? What if you talk about the treatment and you look at just the FDA approved medications today in somebody with pretty substantial coronary disease. If you take all of the randomized trials, and this is an academic exercise, but just from an academic exercise, sort of a nerdy calculation, is if you add up all of the relative risk reductions and you assume that in the person who has severe disease that they would benefit from each one of those, it adds up to over 90% relative risk reduction. What that says to me is that we have the treatments that can eradicate heart attacks from the face of this earth. And we've got so many good ones coming down the pike too, like whether it's IL-6 inhibitors or anti-inflammatories, LP-little-a lowering drugs, and so on. Uh, but where we fail, I think, is in the identification of people. Like, we published a study about 4 months ago looking at 5 million heart attacks across the country. And it turns out these are non-fatal heart attacks. Like, the fatal heart attacks are probably not being included in this because adjudicating the cause of death is sometimes hard when it's sudden and in the home. But what you saw was that over half of the patients will never have a symptom. And amongst those, almost 30% don't have a single risk factor. So they don't see
Hmm.
doctors and they're not treated. So the problem with that is that if you think about it, you can have the best prevention programs in the world, but you'll never see these patients because they die at home. So I think the only way that you can do this is to go up into the home and really try to find everybody who's at risk. And that is the purpose of Transform. And then the last part is the implementation of it. So what we tried to do is really create translational tools, taking imaging and making it clinical and actionable. And then we're reliant upon the doctors, but the doctors who adopt our tools now have the tools to educate their patients and effectively implement. There was a large Kaiser Permanente study where they stack ranked all of the things that contributed to patient adherence. The number one factor, the patient's perception that the condition you're treating is serious. Once they see their disease, they recognize the seriousness of the condition, and you see the compliance rates go up. So I
I
think
can
it's
speak
really
to
around,
that for
yeah.
sure.
Mhm. So it's just identification, implementation, treatment. Like if we can solve those three things, then I think one has largely been solved, the treatment. Now we've got to identify and implement better.
Yeah, the identification, I mean, gosh, considering the fact that sudden death is still a common presentation of heart attacks, I mean, it speaks to the fact that we're clearly missing a lot of that identification, right? Like that's too bad with technology being where it is and the ability to detect this disease is there, right? I mean, and we have the technology, we have the ability to do it. Unfortunately, these things just take a lot of time in medicine to make actual practice changing impacts, right? And then like you mentioned, there's a lot of these people that are going to be at risk that one have no idea. Most people aren't getting their LP little A checked. They're not looking at their genetics, et cetera. They might know their family history. They may not even go to the doctor, like you mentioned, right? They may feel perfectly fine. And or maybe they've slowly changed how they felt over time. I mean, even one of the risk factors, high blood pressure, is typically asymptomatic. So, a lot of these people may have no idea, like you mentioned, may not even be seeking care or may not even know they have risk factors. So obviously more work to do on that front. I did think of one more question while you were talking about that. For individuals with severe disease on imaging, what's the use case in cardiology offices for this? Are you seeing this take off more in cardiology offices? I definitely have a mixed reaction with referrals. To be completely honest with you, some people have never heard of this. Some people are really excited about it. Oftentimes that's age dependent, but not always. And I'm just curious what you're seeing. Like, when is this used? Is this used in place of like screening calcium scores that used to be done when people aren't it's not appropriate to get a cap at that point in time. Like, just curious if you could speak to the use
Yeah.
for
I
cardiology
mean,
offices.
I think you're right. Like, I think we're in an evolutionary stage right now. Like, it's definitely catching fire. We saw the American Heart Association, American College of Cardiology put out a guideline on non-obstructive coronary artery disease just a couple of weeks ago, in which they started to think about the staging system that we talk about in terms of, do you have non-mild, moderate, or severe disease? That was something that had never been in an AHA or an ACC statement before. Similarly,
Mm,
the Lancet, like the journal Lancet, which is widely considered one of the top 3 journals in the world,
yeah.
they commissioned a group of folks to say, "Hey, we gotta shift the paradigm from ischemia or symptoms to atheroma to plaque." And so, like, that came out probably a couple months ago or so. So the field is
Nice.
definitely starting to catch up. Where I think it's most appropriate is in the symptomatic patient, right? So that whole common link, right? It's not only something that can identify and diagnose disease, prognosticate risk, but help determine, do I need to go to the cath lab? Do I not need to go to the cath lab? And what you can do is you can safely avoid invasive procedures in the majority of people. So it ends up becoming a cost savings thing, which is very important. If we can practice precision medicine and it bends the cost curve downwards rather than upwards, that would be a huge thing, because pretty much every technology generally increases healthcare costs. And we think that more judicious downstream referrals for expensive things can be curtailed by doing precision medicine.
Not to mention it's non-invasive, like you mentioned, right? So for that, yes, on a system level, the cost reduction is massive and what will probably change things ultimately. But on an individual level, if that's your spouse, if that's your dad, if that's you, cats are not benign, right? Like they can certainly be life saving and typically are when procedures need to be done. But I'm sure we've all heard as physicians of cases where, things can happen in invasive procedures, right? So if it doesn't need to be done, if it wouldn't change the management, if nothing has changed that would necessitate an action in that calf, then gosh, if we can do it in a non-invasive way, beautiful, right?
Well, I
For
think
that individual.
actually, yeah, you hit the nail on the head. Like, we did a study called Certain, and it was about 750 people, I think. And what we wanted to understand was, like, okay, you got a plain old CT angiogram that somebody interpreted without AI, and then you've got this very advanced analytic approach to CT using the AI. And does it actually change the management? And it turns out it changes the management more than 60% of the time. And so, like, it really does offer very, very useful clinical information to guide how you would approach somebody's care. And that change in management also includes, hey, I'm going to cancel the expensive downstream invasive procedure. You don't need that. You subject that patient to potential harm, to very high costs for no utility. Like, that's a good thing for us to practice precision medicine in that regard.
Yeah. Nice. Thank you so much for, exploring my own curiosities on this. Hopefully we answered a lot of questions for our listeners. I think this is going to be a popular episode because, like I mentioned, we've got a lot of docs that listen and a lot of patients that are super interested in optimizing their health span and their longevity. And as we've mentioned a number of times, this is the number one way really to do that, right? Because this is the leading cause of death and has been for a very long time. So this is, gosh, there couldn't be a more important topic, in my opinion, to explore. So I really appreciate you sharing your knowledge, and more than anything appreciate you, using that knowledge and passion to start and propel a company like this because it's changing lives. I have had a number of cases where I've seen that directly, and I know physicians that are using this all over the place have certainly had similar experiences.
Great. Thanks so much for those kind words,
Yeah.
Aaron.
Yeah, of course.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.